Now, just make sure. So I'd like to thank the staff in Wakefield for inviting me down from Cork this evening, on this wet evening, to present on the conservative management of femur acetabular impingement. When I was an undergraduate 25 years ago, there was no mention of this really. It was kind of an unknown phenomena. And over the years, it's become more and more of an issue, and it's hit the media over the last few years. So I think it's very important that it's part of the discussion here in terms of how can we detect early, improve outcomes to reduce the amount of people that may go on then to have surgery. The Best Practice and Research Clinical Rheumatology Journal earlier this year published this journal, and it's a very interesting review of the current state of play in terms of how to assess and rehab patients with the impingements. So I'd advise you to look at that journal. So tonight's talk, I'm going to be using some of these current concepts and trying to make them kind of appropriate for the clinical setting. So the key to reducing the stress in the athletes is early, accurate diagnosis. So duration of symptoms is probably one of the first things we need to look at, and we're asking patients about the severity, the quality, and the intensity of the pain. Then we always have to remember the red flags to make sure that there's no underlying cancer or infection going on. Then we delve a little bit more into their lifestyle in terms of their training load, frequency and intensity of training, and the ratio that when we compare it to their recovery strategies. Is there maybe too much emphasis on the training when they were 10, 12 years of age relative to the amount of recovery they were going? Then we look at in the nature of their training. Are they doing a lot of drills requiring kicking and twisting, which may be provocative and causing morphological changes? And then we're looking at the quality of the strength and conditioning they've been doing in terms of whether their pelvis is too anteriorly tilted, where they're doing a lot of deep squatting very early in their youth, and look at the twisting combined with that. I suppose I'd also then look at just lifestyle in terms of their posture. Were they sitting in low chairs, excess driving that might aggravate a kind of an inflamed hip. And then the validated scores, so the hip HARS, the WOMAC, the Haggis is developed by Thornburg, are helpful in indicating kind of the level and severity of the symptoms. So Thornburg et al. In 2018 developed this flow chart to help us as clinicians, because we're all working in isolated country settings, a lot of people, and just to kind of decide whether it is hip or lumbar spine. So I'd just like to talk you through this. So obviously the athlete comes in with symptoms, and we know they have groin pain. So we need to look and try to make a differential diagnosis. So I suppose in the clinic I always look at lumbar spine. It's just a habit of mine. I'll always try to look at the sacroiliac joint. I look at the overall biomechanics. So then I'll try and decide whether it's an adductor-related issue or osteitis pubis, or then we can decide on the imaging required for that. Is it inguinal? Is it iliopsoas related? And then as we're trying to using our subjective information to try and decipher down, is it more really a hip issue we're dealing with? So I'm not really going to do much on the test because Mr. Carton has done all those brilliantly. So I suppose the main ones for interarticular pathology would be the Faber and then the Fader. So they're your more basic tests. And then if you're worried about the instability, you move on. I'd always do a Thomas test just to kind of give an idea of the integrity of the muscles in the area as well. Range of movement, we will be looking at reduction, as we know, in flexion, internal rotation. And strength has been always proved to be reduced in situations where there is a hip impingement. So particularly adduction strength, when they looked at it, was reduced. So if the patient comes in and it looks like they have a very inflamed hip, we always try and avoid any manual techniques on the hip itself. We don't want to be aggravating a joint that's already inflamed. I might start with basic isometric exercises, and I'd spend a lot of time educating them about the injury and the need for accurate diagnosis. So maybe going on, coming somewhere like the Whitfield and looking at the angles and the morphological changes on MRI and X-ray. I might get him to do pull-based work to offload the hip, and your main thing is offloading the anterior aspect of it. you're encouraging maybe them to speak to the GP about have anti-inflammatories if it's very inflamed. Then physiotherapy, one of the other areas we need to look at is nociceptive findings. So like if we find that any other structure may be referring pain in there, so we try and rule those out bit by bit, and you can use soft tissue massage or trigger point therapy on muscles like iliopsoas, the adductors, piriformis, hamstrings, rec fem, tensor fasciolata, and erector spinae. And also treat lumbar spine and sacroiliac joint. So once we're kind of happy that we've ruled out some of the other nociception to it, we might look at the rehabilitation. And this study done here, 2018, is a lovely open access study, and it's done on post-operative arthroscopy and trying to find a good outcome. So it's just a progression of exercises post-surgery, but it's the same deficits really that exist for conservative management. Just looking here, balance was also found to be something that we needed to look at. A study in Hatton et al. 2014 found that the balance had to be addressed in all programs relating to impingement. And then you could use a validated test like the star exclusion balance test for that. It's trying to make it more objective. And obviously hip strength is always going to be a big part of our recovery. So we're looking at the same study, Harry et al. 2018 looked at that, and they were using handheld dynamometers to analyse the strength. So I suppose this is probably one of the most important slides. What exercises do we give someone who we feel have maybe early stage impingement but are not quite surgical yet? So we have a focus on hip extension, both in bridge position and in standing, and then a progression on from there. So the visual analog scale is they always encourage it to be kind of 2 and only a very low rate of exertion. This was from the Kemp 2019 paper. Also then looking at trunk stability, you can see the progression there in the side plank. So none of these exercises are very provocative for the hip, and yet they help improve the quality and the strength of the stabilizing muscles that will help offload the forces in the front of the hip. You can see the progression here in functional, although I don't like too much deep squats, but so I kind of start off with them easy and build up from there. And then also the plyometric exercises. So by the time they're trying to return to higher levels of play. So another important aspect of conservative management is education. And there's the Aspeter Hip and Grind had a really good conference in 2016 in the Aspeter Centre. And that's all available freely on YouTube for anyone who's interested to see and looking at the conservative management of that. I find the website here, sportship.com, really helpful for helping patients make decisions, because the more awareness they have, the easier it is for them to make a decision. And I'd always warn them not to be using too much Instagram information, because not all the information is high quality data. In terms of keeping them fit, what do we do to keep the player fit? So stationary cycling or road cycling, but they don't allow kind of mountain trails. Swimming is permitted, aqua jogging, walking flat terrain, cross training. But we all know that athletes have no interest in most of these things. The only thing they are interested really in is the return to play, and that's their final goal. So it can be very challenging as a therapist, because the patient's goals can be met, but there is a lot of work along the way. Once we have done some of the rehabilitation, this study by Inda King showed that it does improve, it reduces the stress on the joint, and the Haga scores were reduced. So it was just an interesting, and that's it's an open access journal as well. So the Warwick Agreement was where they brought a lot of the informed people in terms of the hip together to try and create a little bit more structure in terms of what was the management of it. And I suppose the triad of symptoms became very relevant at that stage. So it's not just the morphological changes, it's the symptom pathology and how that shows, and it's also our clinical testing. So it's meant to be a triad of all those. And then Mr. Carton said to me, we must tell people, how do we decide in terms of who's surgical and who's conservative? And it is very difficult. And some patients come in, the first day they come in, I might tell them, I think you're surgical. There was a patient there a couple of months ago, an 18-year-old just finishing his leaving cert who came in, 3-year history of hip pain that his father had almost stopped listening to because he had seen 5 people, 5 therapists, but nobody had done any impingement test, which was quite worrying. And when I did the impingement test, he had a huge restriction in flexion, huge restriction in internal rotation. So I went out to the car and told his father, come in, I want to talk to you about him. And he ended up seeing Mr. Carton within 10 days and is having surgery shortly because he didn't want to interfere with his leaving cert. But it's just like some patients are very obvious that the morphological changes are so great that conservative management really has to sit back because it can't address those issues. But if a patient comes in and they have quite good range of movement, the impingement testing is not too strong, but you see that they have huge weakness in their glutes, very poor stability, poor biomechanics, and are overtraining, then I think we can address those factors. Okay. Now, looking at the relationship here between FAI, hip pain, hip joint forces, and load modification. So this is how we bring it all together. But I want to make it real. So I heard that Ballysaggart had a big win here last week and that they're going senior. So we visualize at the base here, altered external joint loading. What does that mean? It's probably an 11-year-old child, we'll call him Sean in Ballysaggart, who's inspired by their recent wins and has decided he's going to train really hard for the next few years and that he is a good athlete. And because he's a good athlete, he's playing up in age, up maybe 2 ages, which changes the morphology of his joint, which may lead him eventually to have an FAI or a labral tear. Now, if we look on the side, physiotherapy can have an impact at muscle function and external loading to help reduce the pain and reduce the hip joint forces, and then maybe reduce the surgical rate. But if there's a lot of damage after being created when they're very young, it's difficult for us to catch up with that damage. So I think a role for physios may be actually working with teams and team education, encouraging more recovery and cross-training, and stabilizing the muscles and integrating strength of the gluteal stabilizers, and also emotional support. It's a pity Wayne wasn't here tonight, but I know he would have spoke very much about that. It can be very isolating being injured, and I think sometimes we're the frontline practitioners and we do need to be there for people and, you know, give them a ring every now and then, ask them how are they doing, help them with the progression of their training. So that's all I have to say, really. So in summary, I feel that we need to optimize hip loads using our current knowledge of impairment. I'd advise people to look that study up, the Kemp study, and that lady involved in that is currently running a project in the La Trobe University in Australia, where they're doing a large-scale randomized controlled trial. So I think we will have the answer pretty soon. It's a shared decision-making process. So once we have the accurate information from a clinic assessment, both physiotherapy and surgical, we can kind of decide what's best for that individual person. And I think individualized rehab programs and physiotherapy, we play a role, whether it's pre-operatively, post-operatively, and I think that's important that everyone works together, that's not just conservative on one side and surgical on the other. I feel actually we can all work together and improve post-surgical outcomes by using some of the conservative management. Okay, thank you very much.